All right, everyone. Thank you so much for being part of this meeting. Special thanks to the AstraZeneca team for helping us get together and updating us, creating a forum, essentially, an activity for us to understand what's actually happening in PNH. We are all aware that for forever, for donkey's years, we've been treating PNH primarily one by ensuring that we are diagnosing patients because I'm not sure what percentage of patients remain undiagnosed for their entire life. Second part, not only full-fledged PNH, but the clones, PNH clones, which we see in aplastic anemia, those often get picked up, especially if a hematologist is, managing the patient and has diagnosed aplastic anemia. Besides diagnosis, the only thing that we were doing essentially is dealing with the iron deficiency, the thrombosis, and brief episodes of accelerated hemolysis, and ultimately thinking of transplant when the marrow failed. However, the treatment landscape, which had changed around the world several years ago, is now at our doorstep, and we have novel therapies available in India, and hence it completely makes sense that we get updated about this disease particular. We have an excellent group of speakers from Dr. Samir Agarwal, who is a young and dynamic hematologist, trained in Mumbai in Nair Hospital and then in Kolkata at Tata. Worked in some good centers, and I'm very proud to say that he's part of our team at Mysore right now. Following that, we have Dr. Zer Jeffrey from Melbourne, who's, of course, the PNH expert and who will help us understand this disease in terms of the treatment guidelines and the best practices. And then we have Dr. Radhika, whom I worked with several years ago, exceptionally motivated and hardworking hematologist. Not only does she almost single-handedly manage a large department in the government hospital in Hyderabad, but is also active in clinical trials. And if I'm not mistaken, Dr. Radhika was also part of a couple of clinical trials for PNH. So with this introduction, I welcome you all, and I'll
आ
hand
जाएंगे
over,
भाई.
and we hand over to Samir. Our panelists for Dr. Samir's talk, we have Dr. Mahadev Swami from Goa, Dr. Aditi Shah, and Dr. Abhijit Baheti. I invite the panelists onto the first talk, and Samir, on to you.
Thank you very much, sir. So I'll introduce myself. As sir said, my name is Dr. Samir Agarwal. I am currently associated with Chiron Oncology under the leadership of Dr. Sachin Jadhav. And currently I am handling the Clear Medi multi-speciality hospital. I have been entrusted the responsibility to discuss a brief overview of PNH, paroxysmal nocturnal hemoglobinuria. I'll try to finish my talk within the time limit, and I'll take you through the pathogenesis of PNH in a few slides. I'll share my slides first. I hope I'm audible.
Yes, you're audible. Full screen? Yeah.
Just a second.
Requesting others to please mute themselves.
Yes. So to begin with, paroxysmal nocturnal hemoglobinuria, it is a chronic disease characterized by progressive and debilitating and potentially life-threatening course of disease. It is characterized by sorry, uncontrolled activation of complement, resulting in intravascular hemolysis. This intravascular hemolysis is also associated with thromboembolic events, which can result in organ damage and impair health-related quality of life. There was a study which was carried out in England, a regional study on PNH, which showed that an annual incidence of 0.13 per 1,100 patients, 100,000 persons, and a
Rajiv,
15-year prevalence was estimated to
what
be.
chairs is there taking out? June new chairs will come.
Sorry, I think someone has to
Huh?
mute themselves.
Yeah. Others, please.
Whichever chairs up. Okay, put in the group only.
Dr.
And
Vasant.
whichever sir is telling whichever sir will take now, sir, talk to that sir. They said in June new chairs will come on. So for now they try to take this. Okay.
Dr.
Put. Okay. Okay. Okay.
I request everyone to keep their voice on mute. Just one sec.
Go ahead, Samir. You can go.
So I'll begin my talk again. Basically, PNH is a chronic disease and it is characterized by debilitating and life-threatening course of disease. The major presentation of this disease is in the form of intravascular hemolysis, but it can be also associated with thromboembolic events, which can lead to organ damage and impair the health-related quality of life. There was a regional study on PNH in England, which reported an annual incidence of 0.13 per 100,000 patients, and 15-year prevalence was estimated to be 1.59 per 100,000 persons. PNH can occur at any age, but it is mostly diagnosed in young adulthood, with diagnosis typically occurring in the patients ranging from 30 to 40 years of age. The most devastating consequence of IVH in PNH is thrombosis, which can occur in blood vessels throughout the body, which causes morbidity and can be fatal even at the first stage. The graph over the right-hand corner shows us the historical survival rate in patients with PNH. The first graph over here, which is in red, shows us 6-year survival in a historical control group of patients with PNH diagnosed between 1985 to 2005 in France. So at 6 years, the survival rate of these patients was 80%. In another study, which was carried out in UK, the blue line shows us the survival rate at 7 years, which was 66.8. And a third study carried out in UK again showed 10-year mortality at 50%. So overall, 20 to 35% patients die in 5 years, despite receiving transfusion, corticosteroids, or anticoagulants. As I said, PNS is associated with thromboembolic events apart from hemolysis. The thrombotic events are more commonly seen in venous circulation as compared to arterial, but even arterial instances have also been recorded. When venous system is involved, the patient can present either with pulmonary embolism or deep vein thrombosis. The cerebral venous sinus system can be involved. Cutaneous vessels, hepatic portal veins, abdominal veins can be involved. In cases of arterial thrombosis, patients can present with stroke, transient ischemic attack, or myocardial infarction. These thrombotic events can lead to end organ damage such as CKD, where patients can develop renal insufficiency. They may become dialysis dependent and may also develop hypertension. In cases of pulmonary arterial thrombosis, patients develop pulmonary hypertension and they can present with dyspnea and cardiac dysfunction. The small cartoon on the left corner shows us the genetics behind PNH. In PNH, there is an acquired mutation in the X chromosome, and the gene which is involved is called the PIGA gene, which is phosphatidyl inositol glycan class A gene. When there is a mutation in PIGA gene, there is reduced production of GPI anchored protein, resulting in increased formation of increased complement activation, formation of membrane attack complex, resulting in intravascular hemolysis and further thrombosis. I would go into the depth of this mechanism in the further slide. So I'll move on to the next slide. What is PNH? As I said, PNH is paroxysmal nocturnal hemoglobinuria, and it again has a progressive life-threatening course of disease with thrombosis and organ damage as described earlier, which causes increased morbidity and mortality. The prevalence of PNH is 12 to 13 cases per 1 million, and the median age of onset is 35 years of age. Male is to female ratio is almost similar, with presentation in females in around 53% and in males around 47%. If untreated, as I described earlier, patients can die within 5 years, and this rate is 35%. So I already described what is the genetic behind PNH. So PNH is because of a mutation, which is an acquired mutation in the PIGA gene in the hematopoietic stem. So after this mutation develops, the production of GPI anchored proteins, including the complementary regulatory proteins such as CD55 and CD59, reduces. There is deficiency of these. So what leads to PNH because of this deficiency? Because of uninhibited complement activation in the absence of CD55 and 59, there is increased formation of membrane attack complex, which we call it as MAC, which is composed of complement C5b and complement 9. This complex leads to increased intravascular hemolysis. As a result of intravascular hemolysis, there is increased free hemoglobin in the serum as well as urine. There is increased LDH, and the free hemoglobin causes scavenging of nitric oxide. There is basically consumption of nitric oxide by this free hemoglobin, which results in reduced levels of nitric oxide. So what is the end effect of all these processes? The end effect is increased intravascular hemolysis will cause end organ damage, resulting in CKD, pulmonary hypertension, liver damage. The reduced levels of nitric oxide can cause various muscle dystonias, and patients can present with dyspnea, dysphagia, erectile dysfunction. There can be abdominal pain, cramping, chest pain. The pathogenesis behind thrombosis is there is a fragment which is also produced along with the MAC complex. The fragment is C5a. This is a pro-inflammatory anaphylatoxin, which causes platelet activation. The platelet activation will cause platelet aggregation, leukocyte activation also happens, and all these processes together can lead to cytokine release and increased propensity for thrombosis. As I said earlier, thrombosis can happen in the venous system, arterial system, and the commonest sites for venous thrombosis include the intra-abdominal veins such as hepatic vein, portal vein. They can happen in the pulmonary circulation as well as in the renal. This is the flow chart which is describing the complement pathway. The complement pathways which are involved in PNH are classical pathway and alternative pathway. In the classical pathway, the first is formation of C3 convertase, which leads to the formation of C5 convertase. This C5 convertase splits complement 5 into complement C5a and complement C5b. Complement C5b will combine with complement C9 to form a membrane attack complex. And this membrane attack complex leads to cell lysis, cell activation, release of pro-inflammatory cytokines, ultimately causing destruction of cells, inflammation, thrombosis. And the other arm, C5a, it being a potent anaphylatoxin, can cause anaphylaxis and inflammation. The alternative pathway involves complement C3. This complement leads to formation of C3 convertase and further steps of classical pathway. So what happens in PNH? When there is a deficiency of CD59, there is uninhibited formation of membrane attack complex. And first, there is increased complement mediated destruction of hematopoietic stem cells, predominantly red blood cells. And when there is deficiency of CD55, there is uninhibited formation of C3 convertase, which leads to increased complement production and complement activation. And our treatment, which our other colleagues would discuss, is basically based on the classical and alternative pathway where there is deficiency of the GPI anchor protein. So basically, they are targeted towards the C3 complement and C5 complement. So I'll discuss the rate of hemolysis. The rate of hemolysis in PNH, it depends on three factors. First is the clone size. The percentage of defective hemopoietic stem cells will decide the amount of hemolysis that a patient will have. So in a patient with 10% hemolysis, the 10% clone, the hemolysis would be negligible. Whereas in a patient with more than 50% clone, the hemolysis would be very severe. The second factor which decides hemolysis is the degree of GPI anchor-protein deficiency. So there are three types of deficiencies. The type 1 deficiency where the levels are normal. In type 2, the levels are partially low. It may be around less than 50%, but not more than 50%. And in type 3 deficiency, complete deficiency of GPI anchor proteins like CD55 and CD59. And in these complete deficiency patients, the hemolysis is to a severe level. It is of a high grade. The third factor which can influence the level of hemolysis is the level of complement activation. So complement activation can happen by a number of events such as alcohol intake, blood transfusion, infections, strenuous exercise, and surgery. And I would also like to mention you about the role of infection. For example, in patients with gastrointestinal infection, there is increased propensity of hemolysis because of absorption of lipopolysaccharides from the bacteria and intestine, which can lead to further complement activation. So this slide describes about the types of PNH based on the clone size. In classic PNH, the clone size is more than 50%. So the hemolysis is florid, and such patients do not have any evidence of any other bone marrow failure. And in a PNH in the setting of another bone marrow failure syndrome, like aplastic anemia or myelodysplastic syndrome, these patients have a lower clone size, which is less than 50%. It has mild intravascular hemolysis with evidence of one or more concomitant bone marrow failure, like aplastic anemia, myelodysplastic syndrome, other myelopathies such as myelopathy. The third category is subclinical PNH or non-hemolytic PNH, where the clone size is less than 10% and it is called as a small clone. Such patients will have no clinical or laboratory evidence of intravascular. I think this summarizes the pathogenesis of PNH, and I hand it over to Dr. Sachin.
Thank you, Samir. Thank you for, a very thorough, but at the same time, succinct presentation. Thanks for keeping time. I'll now hand over to Dr. Jeff.
Thank you. Thank you.
Thanks, Sachin, and thank you, Dr. Agarwal, for a great introduction. I will repeat some of the things that you've introduced, but in the context of moving forward a little bit. So I'd firstly like to thank the AstraZeneca people, Pratnya and her team, for inviting me to talk to you again. I was last in India virtually at the end of last year, and I'm looking forward to getting back there in real life at some point in the future. Now, hopefully, I will be sharing the correct slides. I am. So I'm going to go over some of the historical background, but let me put myself into context. I'm a hematologist with a lifelong interest in PNH, but most of my life has been spent as a bone marrow transplant physician, and with particular interest in bone marrow failure. And I first was totally immersed into the PNH world in 2004, when I met many people who are now very close friends in the PNH world at the investigator meeting in New York for the first randomized study of eculizumab in PNH. So it's been a fabulous journey, and I've accumulated a moderate-sized practice, which is very large in Australia, of some 32 to 33 treated patients, and then as has been said, a bunch of patients who have a PNH clone identified but are not necessarily treatment dependent or requiring. So let's just move on. I'll try not to bore you. These are my disclosures. And I aim to cover these in no particular order or order of importance, but I'd like to emphasize to some extent, using the data that we have, that this disease actually presents itself as a medical emergency with urgency to treat, given the number of complications that can occur and how disabling or even fatal many of them can be. I want to emphasize the absolute centrality of lactate dehydrogenase as a biomarker of significance in PNH. I'll touch on, towards the end, bone marrow transplantation, and look a little bit on criteria for treatment, which vary around the world, and also monitoring of these patients, which is extremely important, particularly as options for therapy start to expand. And I want to spend a little bit of time talking about pregnancy, because this is one area where the introduction of anti-complement therapy has made a huge difference to both the mother with PNH and the potential offspring from pregnancy. And I think history is always very important, and perhaps I find this more and more interesting as I get increasingly old. But central to all of this is a paper that was published in the 1950s, where much of this history was unraveled, and much of it was lost. So the initial description, which really described PNH as it was and as it is now, was in 1882. But Strubing, who from Germany, who published a classic description, which is unbettered by any clinical description of untreated PNH today, was largely forgotten until the 1950s in a review paper in Blood. It's always worth keeping in mind what happened before, because much progress was probably lost by a lack of understanding that the disease was actually described. PNH as a term, which I hope I'll show you is a very bad name for this disease, but we're stuck with it, was first coined in 1928, and Ham of the famous Ham test a couple of years later described the acidified serum test, which was the gold standard for diagnosis, until our Japanese colleagues actually uncovered the genetic and subsequent molecular basis of this disease, which you've heard about already, in the form of a PIG-A gene mutation, or a series of PIG-A gene mutations that prevent the synthesis of necessary GPI anchors. So Taro, who has been a speaker at IPIG, that's International PNH Interest Group meetings, really is a major source of pride for the community, and it was really only 30 years ago that this was discovered. But this created the background for the advances that we've heard about. And while the clinical trials for eculizumab started in 2004, it was 2007 when the drug was first approved in the US and in Europe, and subsequently spread around the world. Now, I know the introduction of this therapy into the Indian population has been a bit slower, but there's a lot to look forward to with it being available. When I was a medical student, before we really understood what this disease was, the dark urine in the morning getting lighter in the afternoon and then being dark again the next day was the classical description of hemoglobinuria, which was assumed to be nocturnal. And there were many theories about why it was worse at night. The pH dropped, a variety of other hypotheses. But in fact, we now know that the the urine is more concentrated first thing in the morning. And in fact, we're now well aware that PNH is a chronic intravascular hemolytic process, which goes on 24 hours a day. And while there may be some exacerbations, as we've heard from Dr. Agarwal already, it is rarely paroxysmal in the way that it was first described. It's just that episodes are identified. And you can see the classic symptoms of PNH on the left below the urine samples. Thrombosis is the major cause of fatality and a significant cause of morbidity in patients with PNH. And while classic thromboses in classic areas can be seen like in any thrombotic situation, as you've heard, there are some areas that are overrepresented, such as the cerebral venous circulation, the hepatic circulation producing Budd-Chiari, and arterial thromboses in all sorts of places, including in the cerebral arterial circulation, but also in the skin, and this has been identified. You've already heard a little bit about the appearance of PNH clones in patients with bone marrow failure syndromes. In fact, the working hypothesis, still without a lot of science to support the rationale, is that you cannot have the emergence of a clinically significant PNH clone without a degree of aplasia in the background. So particularly immune aplastic anemia seems to spare PNH clones. So while normal stem cells are suppressed in the aplastic anemia setting, the PNH clone can thrive. And we see this not only in the natural history of these bone marrow failure syndromes, but also after treatment, where the successful treatment of aplastic anemia, for example, with immunosuppressive therapy, often results in the expansion of the PNH clone preferentially, such that what was an asymptomatic or clinically insignificant PNH clone suddenly becomes clinically significant and impacts on the prognosis of the patient, even with normalization of the counts. Now, you've heard a little bit about the epidemiology of this disease. Whatever the actual numbers are, it is an ultra-rare disease by any definition. We think there are about 150 patients with clinically identified PNH in Australia in a population of 26, 27 million, which is one of your small villages, I know. And while the prevalence is, as you've heard, that is likely to increase, and I'll show you why. You've already seen the impact on survival of treatment of this disease, and there's no doubt that the prevalence will increase as that death rate drops and has dropped, and we've observed that over the last 20 years. It's a pan-ethnic disease. There is no population on Earth that is unaffected. It does not have a sex preference. There are some minor differences depending on surveys that are done, but things roughly rotate around 50% for each of the sexes. The median age of diagnosis is in the most productive years of life. But pediatric cases are seen as well. And we also see first diagnosis in the extreme elderly. We've certainly seen patients in their late 70s have a primary diagnosis made. So you can't not think about it just because someone is old or very young. It is there in the background. And we can, I hope, in discussion talk about who should be screened for this disease and how. So you've already heard about this to some extent, but I'll go over it again. The mutation in the PIGA gene results in the failure to produce the GPI-anchored protein. So the important regulatory molecules on the surface of blood cells are no longer able to be anchored there. What you see there is a normal hematopoietic stem cell with its progeny, the erythrocytes, granulocytes, platelets, lymphocytes, and monocytes. And all of these cells do have GPI-anchored proteins on the surface. And certainly for red cells, CD55 and CD59 are the most important when we're talking about deficiency and the development of clinical PNH. The few PNH positive clone cells in the stem cell population with its somatic mutation. And it's important to make people who are involved in genetic diseases understand that this is a somatic mutation in the same way that somatic mutations occur in patients with acute leukemia or chronic leukemias. This is not an inherited disorder. It is an acquired genetic mutation. So genetic disorder does not necessarily mean inherited. But this mutation, as we've discussed, results in the failure to produce a GPI anchor and the protective CD55, CD59 molecules. And you can see those populations of cells that have a phenotype for PNH appear in all of the progeny of the stem cells that lack GPI anchor production. And so you've heard that this is on the X chromosome. It is there. It is a traditional autosomal recessive disease, but it is expressed in women in the same proportion as in men who only have a single X chromosome because of inactivation of the partner X chromosome, a process called lionization. And so you can see the development of hemolysis in patients with the mutated PIGA gene and the failure to produce CD55 and 59 anchors for the red cells result in the unopposed action of complement, particularly the membrane attack complex, which is the enhanced terminal part of the complement pathway with C5b to 9, resulting in hemolysis of red cells in particular within the circulation. But this process is not entirely restricted to red cells, and the deficiency of GPI anchors on platelets in particular also are of clinical significance. So complement is an always-on phenomenon, but it's activated. We have a membrane attack complex formed, and the other part of cleaving C5, which is the molecule immediately preceding the formation of the membrane attack complex, is C5a. This is a particularly pro-inflammatory molecule, and may explain many of the consequences of untreated PNH as we see it in the clinic. And I think that this is probably largely responsible for much of the fatigue that is seen in PNH, although the data are somewhat vague. So the membrane attack complex results in hemolysis of unprotected cells. You've heard already this results in a lactate dehydrogenase rise and scavenging of nitric oxide, inhibition of nitric oxide synthesis. And we know very much about the role of nitric oxide in the maintenance of vascular integrity. And you can see some of these other functions down here that I've hinted at, in particular platelet activation and its role in thrombosis. Hemolysis itself has a direct link with end organ damage and many of the clinical consequences that you saw. Chronic kidney disease is a relatively unrecognized part of PNH, but it is there, it's real, and as you've heard, sometimes results in the requirement for renal support therapy. But pulmonary hypertension and liver damage can also be seen, and most of these are largely based, I think, on microvascular thrombosis, consequent directly on hemolysis, but also on scavenging of nitric oxide and reduction of this, resulting in smooth muscle dystonias and creating an environment where thrombosis is more likely to occur with some other symptoms. Now, if you look at some of these features, the factors that are directly related to survival or poorer survival are chronic kidney disease, dysphagia, abdominal pain, chest pain, and thrombosis, particularly in vital organs. So these are all very important consequences of uncontrolled intravascular hemolysis. And this is the relationship between nitric oxide consumption and plasma-free hemoglobin. And you can see a very close linear correlation between these two parameters. And there is a direct relationship also between both of these factors and lactate dehydrogenase, further emphasizing how important this very simple and cheap to measure biomarker is in assessing response to therapy but also in understanding the prognosis of this disease. So we've already heard, well, I've already spoken, I don't know if you're listening, about smooth muscle dystonia and the effect on platelets, which contributes also to the thrombotic risk. Our friends in Korea who have a long-standing registry of patients with PNH, even in the pre-treatment area, and this is an analysis of 300 patients in Korea who had not been treated with any disease-modifying therapy in PNH, which showed that lactate dehydrogenase of 1.5 times the upper limit of normal was particularly important in assessing outcomes. And this is a direct correlation with mortality in patients with a lactate dehydrogenase of more than 1.5 times the upper limit of normal. Now, these data were not well known when, in fact, were not known at all when the initial study, the Chiron study, randomized study in PNH was set up. And in fact, a lactate dehydrogenase of 1.5 times the upper limit of normal was arbitrarily used to define patients who were eligible for participation in the study. So coincidentally, a number was picked that actually is clinically very relevant and it perhaps attests to the success of the original studies and the subsequent success of therapy as it's made its way into the circulation. I mentioned that thromboembolism was an important part of the symptoms and clinical features of PNH in relation to outcomes. On the bar graph on the left, again from the Korean registry, you can see how the rate of thromboembolism in patients with lactate dehydrogenase of more than 1.5 times the upper limit of normal was much higher than those with a lower lactate dehydrogenase who still had a risk of thrombosis that was greater than the background age and sex match population not shown here. And this is something worth thinking about. Some great doyens of this disease have described it as the most vicious thrombophilic disorder known to man. And the only thing that saves most of the population is that it is an extremely rare mutation that results in PNH. Otherwise, the rate of life-threatening thrombosis would be much higher. The survival curves on the right relate to patients who do or don't have thromboembolism with diagnosed PNH on a time scale, and you can see the survival of patients with PNH is very poor, and at 20 years is under 30%, while patients with PNH without thromboembolism have a survival that is quite close to that of the background population in South Korea, but not quite the same, and the numbers are quite small, and we have better survival data that I'll show you in a few minutes' time. So this continues on the discussion of lactate dehydrogenase being an important predictor, and there have been a number of studies having a look at this. This is from the, again, from the Korean registry with some other data from the International PNH Registry as it was, but is no longer functioning, looking at predictive factors for thromboembolism and what are important predictors. And most impressively, the lactate dehydrogenase of 1.5 times the upper limit of normal or greater has an odds ratio of 12, highly significant. Anemia seemed to bear no relationship to thrombosis, nor did cytopenias. Being male produced a slight preponderance of thrombosis for whatever reason that was, and the presence of significant pain also was significant, probably because of the relationship with microvascular thrombosis, which I spoke about earlier. And if you look at factors correlated with death, the one factor that stands out is thromboembolism. This is in multiple regression analysis and modeling. So an elevated lactate dehydrogenase is extremely important, and the presence of thromboembolism is extremely important as a predictor for death. So all of these features are directly related to patients with intravascular hemolysis, and the difference between those with detectable intravascular hemolysis and those that do not have it is particularly stark. Lactate dehydrogenase is a direct correlate. Hemoglobin is not, and we'll come to many of the reasons why patients with PNH treated or untreated, may have a subnormal hemoglobin level. And you've heard about already the direct relationship between lactate dehydrogenase. Severe debilitating fatigue we know to be unrelated to the hemoglobin directly. There is some relationship with hemoglobin, but this is very different to cancer-related fatigue, which you can relate to hemoglobin very closely. We know that because in the original randomized study, and I may be showing you these data later, we had a significant improvement in quality of life, particularly as measured by the FACIT-Fatigue score, despite an insignificant improvement in hemoglobin, certainly not up to the levels that we would regard as normal. And these are the mortality rates that we've talked about before. Significant intravascular hemolysis is a predictor for mortality, and patients who have a PNH clone but without significant intravascular hemolysis, and that means a lactate dehydrogenase of less than 1.5 times the upper limit of normal, survive very similarly, as we've seen from the survival graph before, to an age and sex match population. And I've already spoken about thrombosis and renal failure being directly correlated with mortality. Now, there's much said in the literature about spontaneous remission. Somewhere between 5 and 10% has been reported from some large groups. I must say that this is very rarely seen, and I've seen it not at all. The one patient who I did look after, who was a participant in the original TRIUMPH study, in fact, did have what looked like a spontaneous remission. Her clone disappeared from one test to another one 6 months later, but in fact, within 3 months, she had overt acute leukemia, and what we saw was a progression of her underlying and previously undiagnosed myelodysplasia into a formal acute leukemia, with that clone becoming dominant. So in my mind, spontaneous remission is a very rare phenomenon, but does need to be thought about, and that's why you must continue to monitor these patients, particularly if they are stable on therapy, as there'll be a small number of patients who do not need therapy at some point along the way. So the point of this exercise is to speak about what we regard as the current standard of care in patients with PNH. And of course, this is not available everywhere. And the drug that I'm going to talk about, eculizumab, may not now be the first choice of C5 inhibitor in many parts of the world, but it is still a very effective agent that has been very well studied with incontrovertible data to support its use, and with very significant effect on the most severe outcomes in PNH. So we do know from the clinical trials and from 20 years of clinical experience after the trial, and from data that's been generated through the International PNH Registry, that the use of eculizumab as a designer C5 inhibitor reduces intravascular hemolysis, reduces the transfusion dependence of these patients, improves symptoms and in particular fatigue, reduces thrombotic events, reduces organ damage, and improves organ damage in the case of chronic renal impairment, and that this improvement can slowly accumulate over many years with ongoing therapy. And the reason for lingering on this slide for a few minutes is that whatever treatment becomes available to you, the control of intravascular hemolysis becomes the most important endpoint of whatever you're doing, because that is the factor that is most closely related to mortality and severe morbidity in these patients. So whatever you do, whatever treatment becomes available to you, the control of intravascular hemolysis is fundamental, and that means a reduction in C5 and the cleavage of C5 into the membrane attack complex in patients with PNH. So just briefly looking at some of the clinical trials that established eculizumab as standard of care, and I've described the TRIUMPH study as one of the bravest studies ever done by a fledgling biotech pharmaceutical company. This was a placebo-controlled randomized study in an ultra-rare disease across many centres around the world. I was privileged to participate in this study, and it taught me a great deal about how one can generate, with a good hypothesis and sensible science, one can in fact learn a lot and change the face of a disease and an entire population. So the TRIBE study had a very hemolytic patient population as its eligible target. These were patients who had been transfused at least 4 times in the previous year. They had an erythrocyte clone of more than 10%, but this became a granulocyte clone later on, and I have not spoken about this already, but the white cell populations are much more accurate in trying to quantify clone size because, of course, the erythrocytes are destroyed in hemolytic PNH, and so the proportion of cells that you count that are not yet destroyed may not be representative of the total PNH cellular population. They also had to have a normal platelet count, which meant, or a normal-ish platelet count, which meant that patients with significant bone marrow failure expressed as thrombocytopenia or neutropenia were ineligible. Despite that, this study managed to accrue almost 100 patients. They were observed and then randomized to receive either eculizumab in what is now a standard therapeutic regimen or placebo. There are many patients who are traveling long distances to receive an infusion of saline every couple of weeks during the maintenance phase of this study, and their lives were transformed at 26 weeks when they were able to flip over to open label investigational product. The second study that was done was the Shepherd study. This was a phase 2 to 3 study where all patients received active treatment, but these patients did not require as significant a transfusion history, but could have a platelet count down to 30. They still required a clone size that was the same and a lactate dehydrogenase that was 1.5 times the upper limit of normal, and lactate dehydrogenase became the primary endpoint. And the Aegis study was very similar, slightly different eligibility criteria, but it was conducted in the Japanese population. And all these studies showed the same thing. That is, patients who, with PNH who were treated with eculizumab had a very dramatic and rapid fall of the lactate dehydrogenase down to, and in some cases below, the upper limit of normal. And this was reflected in the placebo group that you can see in the grey curve, who trundled along with their very high lactate dehydrogenase through 6 months of saline therapy until they received their first induction dose of eculizumab with a very significant drop in the lactate dehydrogenase to join the rest of the group. So, and the other thing we've learned now after 20 years is that these responses are maintained into the long term. I haven't spoken about the risk of meningococcal infection, nor have I spoken about the headache that is seen in a significant number of patients with every anti-complement therapy, in particular with the first or second dose. But neither of these is a major problem. Meningococcal sepsis has not been seen in a patient population that was adequately vaccinated and or received prophylactic antibiotics through treatment. So what was demonstrated was that improvement. Subsequently, it's been shown through the International PNH Registry that patients with bone marrow failure, that is with smaller cellular populations, derive similar benefit in terms of lactate dehydrogenase as patients who do not have immunosuppressive therapy, and it works in the same way in both directions. Thromboembolism is markedly reduced, and patients who develop those few thromboembolic events that occurred post eculizumab treatment were almost exclusively in patients who had a prior thrombosis previous to eculizumab treatment, and you can see that here, and is very similar to what we see in the non-PNH population, where a prior thrombosis is actually a risk factor for subsequent thrombosis. And this is seen in patients who required red cell transfusions as well as those who did not require red cell transfusion. So you can see the effect on reduction of thromboembolism is the same in all patients with PNH, independent of their need for transfusion. You can see that here again with thrombosis, and you can see the impact of that on survival, which is seen in French registry data, looking at patients on eculizumab, patients who had PNH after 1985, and patients who with more historical PNH. The overall survival in this population was a little better than was seen in the British study, but the trends are still in the same direction. Renal function, as I mentioned, does improve with ongoing inhibition of C5 cleavage, and this is an event. This improvement can be seen in all degrees of renal impairment, and the majority of patients do improve independent of what stage of renal impairment they have at the beginning of therapy. So this is looking at survival across a series of studies that have been done to show the effectiveness of eculizumab in survival of patients with PNH. So they are the historical survival long time prior to therapy. This is largely derived from the UK data in a patient population that moved to Leeds under the care of Peter Hillman, and you can see that at 25 years, again, we're down to about 30% of the patients with PNH surviving, while the background population from population data does a lot better than that. The introduction of eculizumab therapy in the first publication from Richard Kelly showed a near complete abrogation of that mortality effect seen in the pre-treatment era, but we know a little bit more about, and this is from a broader UK population. There've been more recent data that from the UK, again from Richard Kelly, published some years ago, which demonstrated that eculizumab has its major mortality normalization in patients who do not have severe bone marrow failure, and that's also understandable. So this is an outcome bar graph across hemolysis, transfusion dependence, thrombosis, fatigue, and effects on the kidneys after more than 300 patients were followed after treatment with eculizumab on clinical trials and not. Again, I talked about headache and ongoing safety. The biggest concern being meningococcal sepsis, and that is something that does need to be kept in mind. Not only meningococcus, but actually Neisseria gonorrhea as well. So Neisserial species in particular seem to have a free rein in the presence of C5 blockade, and so some form of prophylaxis needs to be undertaken, and it is certainly mandatory in most countries to have vaccination against meningococcus complete and up to date. And this is more around the safety in relation to that from clinical trials, very small numbers of events. And interestingly, in France, where prophylactic penicillin or similar agents have been used routinely in all patients with PNH for the last 20 years, independent of the fact that in the Triumph study this was not allowed, they did it anyway. France has never seen a case of meningococcal sepsis in a treated PNH patient. So that's worth keeping in mind. Now, I'll just spend a few minutes talking about pregnancy, and we will have more time to talk about more things, I think, in the panel that's coming. Pregnancy is a dangerous situation for PNH, and when I was a trainee, our advice to patients with PNH was do not get pregnant. Female patients was do not get pregnant, and this was a published advice that was certainly present in the 1990s and earlier, because of the effect on both fetal and maternal mortality, often based around thromboembolism, and particularly postpartum thromboembolism, and fetal mortality was also increased. And these are some natural history data from France, which similarly showed that it had significant mortality rate. And what we did using the global registry was to conduct a survey based on registry participants, but not actually as a registry study, around the world to see if we could identify what happened to patients with PNH who got pregnant who were treated with eculizumab. And you can see what we've got there. We've identified 75 pregnancies in 31 centres and 9 countries over an 8-year period. All of them had a PNH clone size of more than 1%. We defined preterm delivery as being less than 37 weeks, and we looked for 6 months in the postpartum period. Several patients had several consecutive pregnancies, and 8 of them had 2 pregnancies each. And you can see the median age at diagnosis was a little younger than the general population. They were about 29 at the start of the pregnancy, with an interval between diagnosis and pregnancy, a median of some 6 years. And there were 9 cases where PNH was actually discovered in pregnancy, and we haven't spoken again about complement activating events, but pregnancy certainly is a complement activating event, and there are a number of patients whose very small and asymptomatic PNH clone actually becomes clinically significant during pregnancy, or require more intensive management of their intravascular hemolysis if they already have it. So I won't spend too much time here, but we established that the rate of fetal and maternal complications was almost identical to the non-PNH population as published in the UK survey of pregnancy outcomes, that eculizumab in particular did not get into breast milk, and we collected breast milk. Richard Kelly, in fact, ran around the UK after deliveries collecting breast milk samples for testing. There were very low levels found in some patients, but they were not significant levels that would have any impact on complement activity. So this was the basis for eculizumab now becoming the standard of care for patients with PNH in pregnancy. And we can talk about some of the details of how that works a little later if there's time. I just want to spend 2 or 3 minutes talking about the patient who does not achieve your optimal goals of therapy with PNH. So there are many ways of defining a patient that does not perform optimally. They may have residual or recurrent fatigue. They may have persistent anemia or even a transfusion dependence, which may persist or re-emerge. And there are many reasons for all of these to occur. And you can see this figure that Austin Kulasekararaj published now 3 or 4 years ago on behalf of a group of us, but really looking at how you identify what's going on in a patient where you're not particularly happy with the outcome. I will exclude this small population over here on the right that have mutations of C5 that render them insensitive to binding by eculizumab, where you can expect no effect. And this is there are particular mutations that are seen and been most frequently described in the Japanese population, but also in a couple of Dutch patients where an alternative method of treatment might be required. But these are the very few patients who have no impact on complement levels and complement activities, and you can measure this either with lactate dehydrogenase or CH50 total hemolytic complement if that's available for you in any of your laboratories. You then have to look at what happens to the lactate dehydrogenase after treatment. If the lactate dehydrogenase is reduced but still more than 1.5 times the upper limit of normal, you have to wonder whether the dose or the pharmacokinetics is correct, and you need to have a look at, you can have a look at the CH50 as a measure of whether or not it is complement itself that is causing the problem, that is, it's not blocked properly, or there's some other reason for lactate dehydrogenase to be increased. If you've managed to drop the lactate dehydrogenase into an optimal zone, that is under 1.5 times the upper limit of normal, but the hemoglobin is unsatisfactory, that is, the patient is anemic and possibly symptomatic, you then look at factors like the reticulocyte count. And if this is elevated, you need to think about this as being probably extravascular hemolysis, but possibly some other factors as you see in this blue box, which are a little rarer. If the reticulocyte is not raised, then it's likely that you're dealing with underlying bone marrow failure or hematinic absence. The presence of extravascular hemolysis is a topic all by itself. It is a man-made disease. There are a number of ways of dealing with this now, but they're beyond the scope of what I'm talking about today. So, from a pregnancy point of view, we know that eculizumab appears to be safe, even though there is a black box warning on the box, and I'm sure your AstraZeneca people will tell you that the use of eculizumab in pregnant patients is a question for a clinician deciding that the benefits outweigh the risks. I haven't yet told you, but pregnancy, well, I have told you that pregnancy is a complement amplifying event, and it's an ongoing one and increases, and one may find that what were previously very effective doses of eculizumab may be ineffective, or the regimen may be suboptimal for complete control, and this requires a little bit of thought, particularly where free availability of eculizumab is not present. We certainly know that eculizumab improves the outcomes compared to historic controls, where pregnancy would not be considered at all in most places, and now we would regard it as the standard of care in patients with PNH and pregnancy. We don't think it gets into the placenta, gets across the placenta, or, well, we know it doesn't, or in breast milk. And we do know that thrombosis was uncommon, except in one situation. There were 2 thromboses seen in treated patients, and one of them was in a patient that received a large amount of plasma infusion because of postpartum hemorrhage. And we know that plasma contains large concentrations of complement, which would have overcome the complement blockade. So we need to be very wary about using plasma to treat bleeding in patients with PNH, particularly in pregnancy. There is no doubt that this disease is a chronic, unremitting, lifelong condition, and treatment needs to be lifelong unless there is a spontaneous remission or some other disease emerges. So you need to be aware of this, because you can't stop treatment in patients. You shouldn't stop treatment in patients, as you will just put them at the same risk they were before they were under treatment. So we know that the historic treatment of this disease made no impact on the natural history of the disease, so transfusions, analgesia, anticoagulants of minimal value to most of these patients. The background story of allogeneic stem cell transplantation is always there. It is certainly curative therapy, and we can discuss this at some length. It's the subject of a talk I'm giving in Paris at the International PNH Interest Group meeting in mid-May. But I think we'll conclude that where you do have the availability of effective complement inhibitors, you should only use stem cell transplantation in the setting of severe bone marrow failure syndromes, so severe aplastic anemia or myelodysplasia, where a transplant would otherwise be indicated anyway, and occasionally for patients with refractory and severe intravascular hemolysis, where for some reason available agents are not effective. And this is an uncommon event, but may be the case, for example, in patients with the complement mutations I mentioned, or in environments where dose adjustment is not possible and alternative agents are not available, where this would seem to be the best therapy. And you know, we like as hematologists to think about cure as our aim, but in fact, in chronic diseases where you can achieve an effective cure with ongoing therapy, if there's not the economic or other push to keep away from that, then one may find an effective cure is as good as an actual cure when that actual cure carries with it a significant risk of poor outcome, as emphasized in this study from France some 10 years ago, looking at transplants versus non-transplants in patients with PNH, depending on whether they had bone marrow failure or not. And you can see in nearly every setting, the transplanted population do not as well as the untransplanted patient. And it's this sort of evidence that would suggest to me that with rare exceptions, a transplant should not be offered for the primary treatment of hemolytic PNH. So in conclusion, I would say that PNH is a rare hemolytic anemia caused by this mutation in PIG-A that we've talked about, which results in a loss of regulatory proteins on the surface of blood cells, loss of the defensive shield against complement, and the unimpeded action of complement on these blood cells, resulting in the known pathophysiology and outcomes in PNH, including life-threatening events such as thromboembolism, organ failure, and renal failure. Lactate dehydrogenase, an extraordinarily important biomarker, which is directly correlated with the severity of intravascular hemolysis and life-threatening complications such as thrombosis. And I think we now have more than enough evidence to be able to state with certainty that eculizumab has transformed the disease to the point where outcomes have improved significantly with a marked improvement in survival. We are aware that we have a man-made complication of extravascular hemolysis that does produce some symptoms and may result in transfusion dependence, but does not have an impact on survival, as it is not correlated at all with the development of thrombosis or organ failure. So I thank you for your attention, and I hope I didn't go on too long.
No, that was perfect, Jeff. And thanks for that in-depth presentation, going all the way to managing common complications. I would like to invite Dr. Dinesh Burani, Dr. Tulika, Dr. Arun, Dr. Rajesh Kashyap as the panelist.
Hi, Jeff.
Dinesh, good to see you.
How are you?
We're very well. Dinesh was a trainee at our place many years ago.
2002. Thanks. Good to see you on this presentation. Jeff, is there any way we can, with the LDH, we can modify the dose or the duration to reduce the cost? Is everyone response in the same way, or?
No, there are not. And you're well. There may be some small so the problem with eculizumab in the way that it was approved, and I hope I'm not going to offend our sponsor, but is that the dose was chosen as a single dose based on some in vitro data, and it was independent of weight, pharmacokinetics, and we really never learnt until very recently what the true pharmacokinetic activity of eculizumab is. We now know that a significant proportion of patients have complement excursions outside the suppressed range on the standard dose of 900 milligrams every 2 weeks. There may be some people that you can give less to. They're likely to do poorly, but there are certainly many patients who would benefit or would have benefited from a higher dose or a shorter interval. They have different pharmacokinetics, and they often fail to meet your therapeutic goals because of that. There are very few places in the world, and the two notable ones were the UK and the US, where there was free rein on dose and regimen. They could do whatever they liked. And there are certainly some patients in the UK who, until more modern times, were being treated with up to 1,800 milligrams of eculizumab, sometimes weekly. Now, this is off-label, and it was off-label then, but they had a single centre that were capable of determining dose for every individual patient, and those patients did well. The more modern era with newer agents has made the management of those patients a little simpler. Cutting costs is a laudable aim. It would be nice if the actual amount per vial algorithm would change to a treatment package. In other words, let me use as much as I need to or as little as I need to for a patient, and this is what it's going to cost for 12 months of treatment. I've been arguing that with industry for a long time, but it's not a model that the pharmaceutical industry anywhere likes. They like to charge X dollars per vial, and that's what they do. So I don't think dose reduction works for many patients. There probably are some who could do it a little less, but I think they're the minority. They will be small people.
So thank you. That was a lovely talk. For secondary prophylaxis post a stroke, there is now a lot of people using DOACs. But you said that patients on eculizumab, they have very little thrombosis. So patients who are on secondary prophylaxis, after some time, are you able to stop the secondary prophylaxis, and how do you monitor if they're still at risk for thrombosis?
That is a really good question that has never been addressed. So in the original TRIUMPH study, patients who were on anticoagulants at the time they entered the study, and there was a practice in the pre-eculizumab era that anyone with a clone size, excuse me, with a clone size of 50% or greater should be on thromboprophylaxis, and the agent that was used was warfarin back in those days. But in fact, when we looked at and if they came into the study on thromboprophylaxis, they had to stay on it through the trial. If they weren't on it, they were not allowed to begin. Of course, you could treat a thrombosis that occurred, but there were very few of them. And in fact, when the data were analysed, the rate of thrombosis in patients in the trials was greater in those on thromboprophylaxis than not. So if you look at the actual mechanism of or mechanisms of thrombosis in PNH, it is so multifactorial, it is hard to see what the impact of a single point of inhibition of one part of the entire system may do for these patients. So do we use thromboprophylaxis in some of these patients? Yes, particularly if they've had thrombosis before. And to date, no one has been brave enough not to use low molecular weight heparin certainly in the last trimester of pregnancy, where the risk of thrombosis is always thought to be greater. But it's very hard to see how it makes much of a difference. Can you stop it? Yes, I've stopped it. Patients who were on prophylaxis beforehand or on secondary treatment, many of them have come off at their own request, and I haven't pushed anyone in that direction. The evidence is still very thin, and most of them got away with it. We've had a couple of thromboses in those patients, some of those patients, but they've mainly been after thrombogenic events, and two of them were bicycle accidents. So, you know, the normal sorts of things that will happen. So I'm not a great fan of thromboprophylaxis, but I don't see why, if you use it, why a DOAC wouldn't be just as effective these days. This is not antiphospholipid syndrome.
Excellent. And we definitely will immunize patients for meningococcal infections before starting, but and we've just recently had these products available now. So how frequently do you need to re-immunize? Is it every 5 years, or how do you check if patients need to be immunized?
Well, you can't. The general recommendation is to do whatever your national immunization guidelines are. So, which might be 3 or 5 years, and it varies around the world. And we tend to do 3 because it's a little. It just gives you a little sense of security. But nearly all of the patients in Australia are on penicillin or an erythromycin-like product as well, because I don't believe that, there have been some cases seen in immunised patients that can't possibly be totally protective across the whole range of patients. Of course, when you start to talk about proximal inhibition, which we've not, in this setting, and when you get to that in India, if you're not there already, the risks are greater, and the prophylaxis needs to be spread beyond Neisseria species.
Thank you.
Dr. Arun, Dr. Rajesh, would you like to ask anything?
I can see a couple of things in the chat. I don't know if you wanted to address those.
Yeah, in the chat, essentially, we had a question that Dr. Tulika has answered. So the question was, how do we differentiate hematuria from hemoglobinuria?
And that's a really good question. And often when I give this talk to a general population, it's not an infrequent event that patients who end up having a diagnosis of PNH have had an unnecessary cystoscopy. It's very easy to distinguish microscopically. And with the appropriate test strips, you can distinguish red cells from hemoglobin, although they're not free hemoglobin, although they're not widely available, even where I am. The test that is actually of some interest, particularly in patients with an uncertain or spasmodic history, is in fact the urinary hemosiderin, which is a very simple microscopic test. And I like to relate it to PNH the way hemoglobin A1C is for diabetes. That is, it gives you a sense of what's been going on over the previous month or two. So if there's been any hemoglobinuria during that time, you will have positive hemosiderin in the urine, even if it's not actually overtly affecting the urine culture, the urine color at that time, and even if you don't have the availability of formal microscopy. But I mean, it's a good question because it happens in the community all the time. And particularly if patients get into the hands of a urologist, they may well get a cystoscopy before they have a full blood count done.
What proportion of your patients are on eculizumab, and how many are on the extravascular, the other agents which are now available?
Okay, so I've got 32 or so patients on treatment. I have one patient who has stayed on eculizumab in the modern era only. He's a gentleman who's now in his 80s. He's been on treatment since the early days, so for 20 years. And he's very set in his ways. And despite the fact that we have better alternatives for him, he's and I'll qualify that in a minute because it's again an off-label discussion for India, but he just is very happy. Everything's going well. Nothing has changed. He doesn't want to rock the boat. Okay. He also doesn't want a mobile phone. That's another story. It's sort of part of the same thing. And many of these patients enjoy the experience of 2-weekly treatment. You know, they get to interact with a nurse or interact with a day center, and it's part of their socialization. The majority of my patients are on single agent ravulizumab, which is the slightly modified form of eculizumab that has much better pharmacokinetics, and where complement excursions are extremely unlikely, and where they only require an infusion every 8 weeks. So that becomes a much easier thing to manage, and particularly with a population that likes to travel, allows people to go overseas for a period of time without worrying about getting doses of drug in various places. There are, in my population, I've got about 8 patients who are on a proximal inhibitor, either by itself or in combination with ravulizumab. And these are patients with overt extravascular hemolysis who had recurrent transfusion requirements or fatigue, and all of whom have been improved. But not every patient needs it. It's a minority population, but they are very real people. And I could tell you a story if there was time, but I don't believe that all of the improvement in the fatigue is to do with the improvement in hemoglobin. Most patients do improve hemoglobin, but I have one particular patient who I've been looking after for a long time who had an add-on proximal inhibitor, a factor D inhibitor, because of persistent anemia and transfusion requirement. And she had a dramatic improvement in her fatigue almost within 2 days, but no improvement in the hemoglobin. And this is why taking a history is important. She was actually only taking 1/3 the prescribed dose of the proximal inhibitor, but it was enough. It was enough to turn off whatever cytokines or whatever were responsible for the fatigue. Subsequently, on the full dose, she's now nearly normalized her hemoglobin for the first time ever. So and she doesn't feel any better than she did when her hemoglobin was 90. So it's a complicated system. And we're still, I think, dissecting what each individual component can do. But of course, there are many agents around, and we've got clinical trials of new agents that are coming along still. A number of companies who are developing anti-complement agents have jumped off the train. They've looked for different disease targets for their molecules in PNH because it's a fairly saturated population around the world. But there are some newer approaches that might be interesting, like small inhibitory RNA molecules that can turn off the production of some of these controlling molecules that will lead the way forward. I think there'll be plenty to talk about for another 20 years.
Jeff, we have a question considering the cost of complement inhibitors. What would you recommend for the majority of patients in resource-limited settings?
Yeah, I would work hard to try and make drug available. I briefly mentioned IPIG, the International PNH Interest Group. I'm extremely proud of this organization. It's the only organization in the world dedicated to advancing both the science and also the well-being of patients with PNH around the world. We had a meeting at the American Society of Hematology meeting year before last, so 2023, where we managed to get the senior executives of 9 pharmaceutical companies involved in either the marketed or developing PNH therapies. And as a result, and we got global agreement that we should find a way of making therapy available to resource-limited countries. Now, we got a little bit of uptake, and in fact, we now have a program. I don't know if you've heard of the Max Foundation. This was the organization that was set up to basically to get imatinib in Africa. Yeah. And it was very successful. So the Max Foundation is now partnering with one of the companies with a newer oral therapy to make it available in African countries. And that took 1 year only to get put together with a signed agreement amongst the 3 parties. So I think there are ways forward. And I'm glad, Dr. Seth, that you've heard about Max. I knew about it vaguely, but until I met the people involved in the organization, I wasn't aware of how dedicated they are to really doing good. And the rare disease space, in fact, is ripe for this, but it involves, PNH is quite complicated. Just giving someone in Malawi a bag of tablets and saying go away and treat your PNH is not what you need. It's only a small part of what you need. You need to establish diagnostics and monitoring and ensuring quality. So all of that comes along with it, and it's a significant challenge, but there's a start being made.
I would like to invite Dr. Abhijit Baheti, Aditi Shah, and Dr. Mahadev Swami. They were part of the panel for the first talk, and since we have finished the overall presentation, if they have any questions to ask, and Samir, you've raised your hand, you could start with your question.
Yes, sir. Actually, I just wanted to ask Jeff about his experience, any experience with C3 inhibitor in cases of PNH.
So the question was the use of C3 inhibitors. So we participated in the Pegasus study of pegcetacoplan, which is a subcutaneously delivered twice weekly C3 inhibitor. The study that we participated in was in patients who were stable on eculizumab at the time, but had a suboptimal hemoglobin. It is an effective agent. It, like all of the single agent proximal inhibitors, it has some worries associated with it. So as we continued to use it through the trial and the post-trial period, it became obvious that a proportion of patients develop breakthrough hemolysis. And breakthrough hemolysis is an interesting phenomenon. This is intravascular hemolysis. You've turned off the extravascular hemolysis with the proximal inhibitor, but some patients with the complement amplifying condition that's obvious, like an infection, or other patients with no obvious reason can suddenly develop a dramatic hemolytic episode with a massive drop in their hemoglobin. They get very sick. They may develop thrombosis. They often require hospitalization, and it's taken us some time to work out how to manage these events when they happen. The concern is that when you treat someone with a proximal inhibitor, very soon after you start treatment, 100% of their red cells in the circulation are PNH cells. They have no cells of non-PNH phenotype. It's always 99 or 100%, which means that if there is a breakthrough in complement activity for whatever reason, and you can see spontaneous activation of C5 even when C3 is fully inhibited, that you've then got this huge population of cells available for instant destruction. So it's a much more dramatic form of hemolysis than we saw in the same patient before they were treated with anything. So there are some concerns with that. And so the proximal inhibitors do have a role. And there are many of them now around. There's another one that is approved in the US and Europe, and soon will be in Australia. At the moment, I have no direct experience with this one, but it's a very convenient tablet to take, but also runs the risk of breakthrough hemolysis. And I worry about patients on these agents who, for example, require fasting for surgery or have significant gastrointestinal illness? What's going to happen to them when they can't actually absorb the dose that they require? And this is not the same as patients on Gleevec, who we know, going back to the imatinib story, we know the adherence to therapy is relatively poor, but this is not a condition which will break through if someone misses a tablet or two. If they do get a bit of a signal, they re-establish control very quickly once they get back on the medication. In PNH, missing one tablet or one injection of the proximal inhibitor could result in dramatic and possibly fatal intravascular hemolysis. So they're not as simple as they look. They do make a difference to the hemoglobin and the well-being of patients with symptomatic and clinically significant extravascular hemolysis. No doubt, they're very effective agents, but are they the complete answer? I don't know, and I'm saying that while one of the proximal inhibitors is now trying to get approval for first-line therapy in Australia, which worries me a little bit. I am a great believer, based on decades now of evidence, that the blockade of C5 is the most fundamental important therapeutic aim in the management of this condition.
We have a question in the chat box. Dr. Rajiv has a patient with hemolytic PNH, a clone size of 79%. And this was diagnosed during her last pregnancy. She's now 5 months post delivery and does not have a match related donor, cannot afford eculizumab, and should he proceed with a haplotransplant? That's the first question. Second is about spontaneous remission. Considering that the PNH was diagnosed during pregnancy, what are the chances of spontaneous remission now?
So the answer to the question depends on what's happened to the clone size in the 5 months after pregnancy. I mean, if it's dropped back to a clinically insignificant level now, the advice would be don't get pregnant again and just watch it. I think if you make a decision that this patient requires a haploidentical transplant, you do that with the knowledge that this is a young mother, presumably, who will have a significant chance of dying or becoming chronically unwell, and in fact worse than she was with the PNH because of chronic graft versus host disease. The risk of this is not insignificant, and it's like it is in aplastic anemia. It's the reason not every transplant in aplastic anemia produces your appropriate outcome. But of course, it is life-saving and life-saving therapy for those patients. So how long should you wait to go for a haploidentical transplant? I'd say I'd wait long enough for more ready availability of complement inhibitors for your patients.
Dr.
Clone size remains the same. This patient will not undergo
Yeah.
spontaneous remission.
Yeah. So, Dr. Abhijit, Aditi, Madhav Swami, anything from your side? Okay.
Does Dr. Agarwal have his hand up again? Is that what that
No,
means?
no, that's the previous one. So now let's proceed to our case-based discussion. I would like to invite Dr. Radhika to go ahead with her talk. Dr. Girish Badarke, Amber, Dr. Abdul Qadir might not be able to join. He had some technical issues, but Dr. Girish, Dr. Amber, if you could please join the panel, that'd be great. And Dr. Radhika, please go ahead.
Thank you, Dr. Sachin. Thank you, organizers. I am Dr. Radhika. I am working as a hematologist at Nizam's Institute of Medical Sciences, which is a government hospital in the southern part of the country. So the hospital where I'm working is 60 to 70% of the times we cater to the low middle economic status people. We do not have the affordability of eculizumab. We do not have the access of eculizumab. So I would like to present two of my real cases, how we manage in a resource constrained setting. So I shall share my screen. Am I clear with my screen?
Yeah, if you could go into the full screen mode. Yeah, this is fine.
Thank you, Dr. Jeff, for your wonderful presentation. So the data on eculizumab is really very astonishing, but unfortunately we cannot recapitulate the same in our country, especially in a setting where I'm working. So I would like to present my cases, how we manage in our settings and all, and these are my real cases. So directly going to the case proper, this is my first case. It's a 19 years female, no comorbidities, presented in January 2019 with complaints of shortness of breath, easy breathability of 1 month duration elsewhere in some other local hospital. She was evaluated for the same elsewhere. The CVP showed a hemoglobin of 7.7, TLC was 5,000 with 21% neutrophils, and platelet count was 10,000. He was diagnosed and managed as ITP elsewhere. 4 doses of methylprednisolone was given with no response. That's when they did a marrow. The marrow was hypocellular with 60% small lymphoid cells. Bone marrow biopsy was hypoplastic marrow with lymphoplasmacytic infiltrate. And then the patient was referred to us to NIMS Hematology. So the case was initially misdiagnosed as ITP, managed with some steroids. Later on, they did a marrow, they redefined the diagnosis. The case was referred to a higher center, that is to us. We reevaluated the patient. The hemogram at our hospital was 6.9 was the hemoglobin, 5,000 WBC with an ANC of 350. Platelet count was 4,000 and an ARC, absolute retic count was 7,000. Rest all parameters were kind of reasonable within normal limits. LFT showed mild elevated borderline bilirubin. LDH was borderline elevated. All the secondary causes of marrow hypoplasia were ruled out. Autoimmune profile, ANA was 2+, but other autoimmune markers were negative. The secondary causes like viral markers, ultrasound abdomen, X-ray were all within normal. The specific investigations like marrow was done, which was markedly hypocellular with a lymphoplasmacytic infiltrate. PNH by flare showed a small clone, which was less than 10%, insignificant, does not cause any kind of hemolysis. Stress cytogenetics was negative. She has a HLA 10-button matched sibling. A diagnosis of acquired aplastic anemia was considered. We routinely do in aplastic anemia PNH screening for all the patients. Out of 77 patients of aplastic anemia whom we have treated with ATG, ACE therapy, ATG, elcromopag and cyclosporine, our data showed around 36.84% of PNH positivity. However, majority of the patients, around 90% of the patients have a PNH clone of less than 10%. We offered these treatment options. The best option we offered was the hematopoietic stem cell transplant for this patient as the patient was young, but the patient deferred for upfront allogenic BMT, though I have a 10-by-10 match sibling. So we went ahead with ATG, elcromopag and cyclosporine. Within 6 months, the patient had a complete remission, 10.2 hemoglobin, 5,000 WBC with an ANC of 2,000 plus and platelet count of 1.2. We continued the cyclosporine for almost more than a year. Elcromopag for 6 months and stopped. There was an improvement in fatigue and overall quality of life of the patient. The patient was all well. Down the line, 16 months after the ACE therapy, in April 2021, the patient presented with complaints of shortness of breath, yellowish discoloration of eyes, and high colored urine. The CBV at presentation was hemoglobin was 4.5, WBC was 4,155% neutrophils, and a platelet count of 15,000. So this time it was only the issue of a hemoglobin anemia. LFT showed a mild indirect bilirubin and LDH was markedly elevated. Creat was also on the upper side, 1.7. PNH was suspected here. PNH screening by flow confirmed our diagnosis of PNH with a PNH clone of 84.5% on RBC, 89% on granulocytes, and 84% on monocytes. Therefore, a diagnosis of aplastic anemia status post ACE therapy 16 months with PNH transformation was considered. So, how do we manage in a resource constraint setting? This is how we manage all our PNH cases. Upfront, we put these patients because we do not have an access for any of the complement inhibitors. We initiate the patient upfront on oral Vicelon at a dose of 1 mg per kg and add on some immunomodulator like danazol and work up for a transplant for these patients and support these patients with packed red cell transfusion. So as like a routine practice, even this patient was initiated on an oral Vicelon at a dose of 1 mg per kg plus added on danazol. Packed red cell transfusions were supported. In spite of the treatment with steroids for 3 months, there was an ongoing hemolysis, and in view of significant PNH clones affecting RBCs and WBCs, she was recommended to have sibling allograft, as this only will offer a potential cure, and I have a 10-by-10 matched sibling sitting by the side. So this was the option of allogeneic PMT. Subsequently, she underwent a sibling transplant on 17/7/2021. The conditioning treatment we used for flu bu ATG. We encountered some complications, not so very grave. Febrile neutropenia and grade 3 mucositis was what we encountered, and we could safely get away with this. She engrafted on D+15. January 2022, that is approximately 6 months later post-transplant, she got admitted with complaints of fever, severe perianal pain, and cytopenias, evaluated and managed for the same, but succumbed to COVID in February 2022 during the hospital. So not only COVID, she had multiple bacteremia too, with superadded COVID infection, and finally she succumbed 6 months post-transplant. Otherwise, we had a successful post-transplant period here. So most of the cases we do manage this way. The moment a PNH is diagnosed, we put them on either a full dose or a half or 0.5 mg per kg of steroids. We try on steroids for almost like 2 to 3 months. If we don't get, if the response is suboptimal or no response is seen, we invariably take up the patient for a transplant. We are more comfortable with doing a full match transplant, but haplotransplant in a benign condition like a PNH with not very great data available in the literature, we are very skeptical to consider these patients for haplotransplants. So this is the most recent case we have encountered just 4 months back. This is a 20-year male presented to Hematology OPD in January 2025. He was born of a non-consanguineous marriage. There were no prior comorbidities. He presented with complaints of transfusion-dependent anemia since 1 year. He received 6 packed red cells till date. A marrow was done, which showed a hypercellular marrow, 90% cellularity with erythroid hyperplasia. There was, transfusion-dependent anemia since 1 year. Subsequently, LFT was showing an indirect bilirubin, a marked LDH, all features favoring that of the PNH. A marrow was done which was hypercellular, 90% cellularity with erythroid hyperplasia. There was no evidence of dyspoisis or abnormal cells. Stress cytogenetics was negative. PNH screening by plate showed a large clone of more than 90%. However, initially the way he presented, the suspicion was more towards an aplastic because he had some a suspicious phenotypic abnormalities, a short stature, everted ears, capillate spots. So on the upfront, when he attended the OPD, he was driving us more towards a bone marrow failure rather than towards a PNH. No wonder that's why he was worked up like an aplastic, like a marrow failure syndrome. A marrow was done, a stress cytogenetics was done to rule out a Fanconi. However, a PNH screening by plate showed a large clone of more than 90%. And to add to our confusion, when we ran the next generation sequencing, it popped up a hemizygous dyskeratosis congenital mutation. He was initiated on steroids and danazol, and he's on these medications for the last 8 months. There's no response. We have planned to take him up for a transplant. He doesn't have a sibling. He doesn't have a sibling, HLA matched sibling, or he doesn't have a mud donor. The best, his mother is around 6/12 match. So this is the bone marrow of the patient. He's a 20 years with a 70% cellularity, erythroid hyperplasia with reduced megakaryocytes. The MEX were only 0 to 1% for hyperactive. The PNH showed a large clone of approximately 78% on granulocytes and monocytes, 83.3%. So an NGS was run because initially the case was more like looked upon like a marrow failure syndrome, which showed a hemizygous DKC mutation, and also patients do have some suspicious congenital phenotypic abnormalities. So this created a confusion. How do I justify the diagnosis here? An inherited and acquired clone in the same patient. So the patient has a significant PNH clone in the range of around 90%, and also the patient is harboring a DKC mutation with some suspicious phenotypic abnormalities. How do I take this patient? Do I take this patient as an inherited or an acquired? I have planned for allogeneic transplant, but while considering for a conditioning regimen, should I be considering this case like a DKC, a PNH, or how do I plan my conditioning? It's a confusion what we are going through right now in our team. So to conclude my presentation, complement inhibitors are the main treatment for classical PNH. We all know treatment is generally indicated for symptomatic patients with hemolysis and evidence of high disease activity. Subclinical PNH do not need a PNH treatment. If it occurs in concurrence with a marrow failure syndrome, the initial focus is always on the marrow failure disorder. So treatment, but however, in our scenarios where eculizumab or other C3 inhibitors are not, we do not are not accessible. Even if we are able to access, we do have some financial constraints, and our patients cannot afford the C3 inhibitors. So transplant is the option available for us, and it is still the only curative therapy for PNH, but it is associated with significant morbidity and mortality. The International Bone Marrow Transplant Registry reported a 2-year survival probability of 56, only 56% in 48 recipients of HLA identical transplantation between 1978 and 1995. Both HLA matched and haploidentical donors have been successfully been performed in PNH patients. Interestingly, the later approach, that is a haploidentical transplants, have been shown to have a more better responses, more positive responses when compared to the HLA match, probably because of a factor like a graft versus PNH effect. Effective non-transplantation therapies are available to treat PNH, but we do not have the access to these medications at this point of time. We still practice allogenic bone marrow transplant only for PNH patients with life-threatening cytopenias or with disabling hemolysis or thrombosis. We are comfortable with managing these patients when we have a HLA matched sibling or a mud donor, but haplotransplants in a PNH patient is still an insecure factor, especially in our center. With this, I would like to conclude my presentation.
Thank you, Dr. Radhika. Dr. Girish, would you like to ask anything? We have Dr. Girish, Dr. Ambar.
May I ask Dr. Sethi a question while I'm here?
Yes, please.
Just to clarify, when you said he was transfusion dependent since 1 year, that to me that meant since he was 1 year of age, but I think you meant for 12 months prior to the presentation. Is that right?
Yes, sir. Almost 8 months we have delayed his transplant.
Yeah, he didn't spend his whole life requiring transfusion. So you described an absolutely unique case, this one, because the traditional wisdom is that you do not see inherited bone marrow failure syndromes in patients with diagnosed PNH. The clones are meant to be incompatible with one another. And I think there's only been one other case reported. So this one is quite unique. But I think that by itself, as you've said, is an indication for allogeneic stem cell transplant, if you can manage to do it, because he will that bone marrow failure syndrome is likely to kill him than the PNH. But it's intriguing. It's intriguing that, and I presume he had none of the other stigmata of disc keratosis congenita. It was all hematologic. Is that right?
He does have some suspicious phenotypic abnormalities. He's short statured, he has some everted ears. When we examine him with this background of DKC mutation, we can also find some kephaloid spots on the back. So
right.
That even more like intensified our suspicion of a DKC. So how do I take this DKC mutation in a PNH? The clone size is somewhere around 90%. It's a large clone.
Yeah. And you, I presume you didn't look for PIG-A mutations. This will be a targeted gene that you look for. Do you look for PIG-A mutations?
Not really, sir. We don't.
Because I mean, I think if you looked for a PIG-A mutation in this patient and you found it, you would have a very impressive case to present to the world. That would be the one clincher, just to confirm that I think there's no doubt the patient will have, unless there's some other associated mutation that is producing a PNH phenotype, which again would be a world first. So this is more than just an oddity. It's actually very, very unusual.
What was that mutation you mentioned?
PIG-A, the gene that's responsible for the gene. Yeah,
sure.
PIG-A. Yep.
Jeff, do you normally test for PIG-A mutations in PNH patients?
We do not.
We don't specifically, but we do a broad screen. We've got that capability in our institution for patients with bone marrow failure syndromes. So we often pick up the PIG-A mutations in these patients while we're trying to sort out what the cause of their bone marrow failure is.
And
But
have
we
you?
would not specifically go looking for inherited bone marrow failure gene
Yeah.
mutations, someone with established PNH. PIGA gene mutations are not a diagnostic criterion for PNH.
Okay. And have you ever seen a PNH since childhood, something like a congenitally inherited? Is that
No.
possible? No. You've never seen.
No, the youngest one I've been made aware of, I think, was a 12-year-old, 11, 12. That's not super uncommon, but true early pediatric cases are very uncommon.
What do you think is the reason why patients with the PNH clones, um, move on to get leukemic transformation? Does PNH lead to genetic instability, acquisition of novel mutations? What do you think causes this?
I think most of them have probably got a myelodysplastic syndrome at the time of diagnosis. There's that Venn diagram that was presented by our NIH colleagues years ago that looks at MDS, MPN, bone marrow failure syndromes, and PNH, and they're overlapping Venn diagrams. So I suspect that's what's done it. The one patient I've had that has transformed to leukemia was not in the PIGA positive population. It was a different clone which actually overtook the marrow function. So I'm not sure it's always the PIGA deficient clone that actually evolves. I think there are other mutations, and not infrequently we do find ASXL1 or other common myelodysplastic mutations at the time of diagnosis of PNH, but not inherited bone marrow failure mutations.
Yeah. What about the perseverance of the PNH clone post-transplant, and you said that it actually overtakes, and why does that clone have a survival benefit compared to the other
Well,
cells?
so this is not post-transplant. This is in the evolution of PNH from aplastic anemia or bone marrow failure syndromes, and it survives because of some form of resistance to the T cell attack in regular autoimmune aplastic anemia. The post-transplant setting, I published my first paper on PNH in 1984, and it was the largest series of bone marrow transplants for PNH ever published at the time. It was 4 patients, and managed to get it into the annals of internal medicine because it was such a unique observation. But what we demonstrated in that small population of patients was that you do need to use some conditioning, even in the syngeneic setting. If you've got an identical twin, so it needs more than just the addition of new stem cells. But our experience in the post-transplant setting in PNH is, firstly, the patients are very complicated transplants. They behave in a, they get in, and your patient is a great example of how you can get into trouble with these patients. But the PNH clone disappears very rapidly. The cells persist for some time. So my advice to people in a resource-constrained environment that are treating a PNH patient with allogeneic transplantation is to try to get some complement inhibition into them before you start conditioning, and continue it until there's been complete chimerism. So when the red cells are all of donor.
Dr. Amber, could you please mute yourself if we are getting sound? Samruddhi, could you please mute whoever is not speaking? Yeah. Jeff, we have a question from Kenya. Dr. Matilda wants to know, again, in resource limited setting, complements, we can't afford, inhibition. And what about transplant? Should they continue to recommend transplants for patients or not?
Look, it is an effective form of therapy. It's curative, there's no doubt, but it comes at a cost. I don't mean a financial cost. It comes at a cost of morbidity and mortality. So, provided you put that into the equation, I know that there are large parts of the world where a transplant, which when I first started in transplantation for more than 40 years ago, was regarded as the most expensive form of therapy in medicine. Now it's regarded as cheap, which shows you how far we've come. But yeah, it's an effective therapy. I must also say that steroids have no place in the management, in the long-term management of PNH. There is no evidence that steroids have an impact on hemolysis or on transfusion dependence. They can assist in short-term inflammatory exacerbations. There's no doubt that you can make some patients feel better, but I think the prolonged use of corticosteroids, and I presume that loan that you mentioned, that trade name is prednisolone or prednisone. This was a 1970s. I've got nothing else to do, so I may as well use some steroids, which is reasonable. Many people have read The House of God, I think, as medical students, and no person should die without a trial of corticosteroids. It's not an unreasonable thing to do where you've got nothing else, but I think it's the toxicity of steroids in long-term use far exceeds any minor benefit that may be derived. So short-term use for inflammatory complications, sure. Long-term use in an attempt to improve the natural history of the disease, unlikely.
By short term, how soon do you taper and stop steroids?
I wouldn't use it for more than a week or two.
Okay.
In the setting of, for example, some form of febrile illness that's undiagnosed that has exacerbated hemolysis. You may well be able to improve the well-being of your patient a little bit under those circumstances. I mean, the other thing we used to use in the old days was a hypertransfusion program similar to what we do in the thalassemics. And hypertransfusion has some theoretical advantages of turning off an exacerbation by suppressing the PNH clones. So you stop the production of PNH cells and reduce the proportion of PNH positive cells in the circulation. But that's again that has some consequences associated with it.
Dr. Tulika wants to know whether Max Foundation is working on getting eculizumab in resource limited settings.
It is. Africa's the first target, but that's not necessarily where they'll end. You're in an unfortunate situation in India where you look like an almost first world country from a healthcare point of view, and you've got some excellent facilities, and where many things are available that are not available in what used to be regarded as the third world, and we call now the developing world. Yet there's still an inadequacy of public funding for essential treatment, and I think that's what I'd be working towards. It's not something, to me, it's an essential human right, and these treatments by definition are unaffordable by individuals, with few exceptions. I think even Elon Musk would have trouble paying for a lifetime of therapy for PNH. He'd certainly have to give up some of the other things he was doing, I think. So, I think that this is countries need to look after their populations.
Yeah. Dr. Matilda, I'm guessing to access, I'm sure once Max Foundation sorts things out as to how they're going to provide compassionate access, we'll get more information. There's a question, the two questions from Dr. Aniket Moite about first, do we know why some patients have thrombosis while others move towards pancytopenia? And the second question is, what's your conditioning regimen for PNH transplants?
I've done, since 1984, I've done very few transplants in PNH. So, but I can tell you that those that we have done, and they've all been done for patients with aplasia or overt MDS resulting in clinical problems. The regimen of choice has been fludarabine, cyclophosphamide, and ATG. We use ATG in all non-sibling transplants, and the majority of them are unrelated donors or haplos. So Flu-Cy would be our commonest regimen. We have used cyclo ATG alone in patients with pure aplasia and PNH, because the aplasia was the indication for transplantation. Why do some patients have only thrombosis while others pancytopenia? It's a very good question. I don't know, but anyone, no matter how cytopenic they are, has an increased risk of thrombosis. So it was always assumed that Asian patients had a lower rate of thrombosis because there was a higher rate of aplasia. But in fact, the Korean registry debunked that completely. And, the hemoglobin as a marker of aplasia was in fact an irrelevancy associated with thrombosis. It was all to do with lactate dehydrogenase.
We have a patient query from Dr. Ramesh. 60-year-old gentleman, hemolytic, basically PNH, and with every hemolytic episode, the creatinine jumps up. Requires blood transfusions. Should he continue? Should he give steroid danazol and maybe add ATG? Primarily for a hemolytic PNH with some moderate thrombocytopenia. So I'm guessing aplastic anemia is setting in, and whether he should continue steroids plus danazol and whether he should add ATG. Is not fit for transplant and no funds for eculizumab.
Of the things you put up there, ATG and danazol look like reasonable things to attempt to improve bone marrow function, but you run the risk of worsening his PNH and hence worsening his chronic renal impairment, which is only going to get worse with uncontrolled intravascular hemolysis. So it's a worry, and these are the sorts of patients I really worry about. You need to get him employed by the government. Do the public servants get access to eculizumab?
Yeah, if they are in the right employment.
Yeah.
Okay.
And
Yeah.
when you say he's not fit for bone marrow transplantation, I mean, while I don't advocate transplants for these sorts of patients, this is one where getting in before he develops end-stage renal failure may be important. And when I started in transplantation, 35 was considered geriatric, but we regularly transplant people in their 70s now. So if age alone is the exclusion factor, I'd revisit that.
There's a question that I have, Jeff. It's very clear about the relation between thrombosis, the clinical features, and the overall survival in PNH. But PNH testing is truly not part of most of the panels which are done for evaluation of thrombophilia. And not only that, but what do you think about young strokes, patients with young AMI, young patients who get AMI? We don't routinely test for PNH. Is there any data saying that, we should be doing it? Yeah.
I think that any unexplained thrombosis in a young person, particularly in an unusual site, deserves a PNH screen, even if the blood film doesn't show it. But I think before that, you need a lactate dehydrogenase, because it's very likely that if it's a PNH related, the LD is going to be elevated. I actually started a project some years ago with it never went anywhere because I couldn't find anyone interested to do it. But I work in a large tertiary hospital, and there's a significant proportion of young unexplained strokes, young unexplained AMIs. And the project that I set up was really just to evaluate how many of these patients had a lactate dehydrogenase measured. In other words, where was the opportunity lost? And in fact, some of the infarcts had a lactate dehydrogenase measured, but not a single stroke did. So there's a huge opportunity lost, and most of them were not screened for PNH. If they come across my clinic, they get screened. I reckon our lab does more PNH flow cytometry than they do many other things, but it is a much more thrombophilic condition than any of the inherited thrombophilias that we test for routinely.
All right. So those are the questions from my side. If anybody else would like to ask, we have 2 more minutes before we close.
Can I ask a question?
Yeah, please.
So, Dr. Jeff, I have a young lady who happened to be a significant PNH clone positive. The PNH clone is somewhere around 70 to 80%. She's not actively hemolyzing. She's maintaining a hemoglobin of more than 10. There's no thrombotic episode. She's asymptomatic lady, but a significant PNH clone. I just kept her on follow-up. I did not put her on any medication. But every time I'm worried that what if she lands up with a CSVT or some kind of thrombosis? So should I be just keeping her in observation and follow, or anything more than that for her?
So what's the lactate dehydrogenase? Is it elevated?
It's a young lady, PNH positive, 70 to 80% PNH clone, no active hemolysis, no thrombosis.
No,
So the
LD,
lactate dehydrogenase is normal, is it?
Yes, sir. Yeah. Got it?
LDH?
LDH is elevated. LDH is elevated somewhere in the range of 300, 400. Bilirubin is 3.6 indirect. But her hemoglobin is, she's maintaining a hemoglobin of more than 10. It's not dropping to less than 10 grams.
Yeah, so she's got compensated hemolysis and good bone marrow function, and she's at risk of thrombosis.
Yes.
So you might want to anticoagulate her if you haven't already, but there's not much evidence that that's going to make much difference. So I think all you can do is hang on to your hat, because at some point, I've got a patient like this as well, that is on the borderline of requiring treatment, but doesn't meet our national criteria. The one thing she probably has without knowing it is fatigue. And we found this in the original, in fact, in every PNH study that we've done in previously untreated patient. Many of them were, lived with a certain level of energy, and they thought that was normal. They knew no different. And we had patients, we knew who was on the treatment arm of the Triumph study and who was on placebo the day after their first infusion. Because people would ring up my nurse, who's still with me and still looking after PNH patients 20 years later, would ring him up and say, I didn't know I could feel like this. And so these are people who would have filled out a quality of life survey and been perfectly normal, but they weren't. So that's one of the other things. So maybe it's better they don't know if you don't have access to therapy. But your patient who's not anemic with no other symptoms and no history of thrombosis and normal renal function would actually not qualify for therapy in Australia, for funded therapy. Would be treated in the UK, would be treated in the US, could not be treated here.
I have not been treating her. I just kept her on a follow-up every 2 months. But every time she comes, I'm worried that what if she lands up in a thrombosis, CSVT,
Yep.
I'll altogether lose the game.
yeah.
Yep. She's certainly at risk, but not everyone does, as we've heard.
Yeah.
Thanks.
All right. This was a fantastic session of understanding the biology of the disease and practical clinical issues. Again, thanks to the AstraZeneca team to make this happen. Thank you to all the panelists and speakers for your participation on such short notice. And finally, Jeff, thanks a lot. It was wonderful getting to know you and your insights based on your experience. Over to the AstraZeneca team if they would like to give some closing remarks. Okay, I think we're done for the day. Thank you, everyone. Thanks, Jeff.
Thank you.
Thank you,
Thanks
sir.
for the invitation. Bye-bye.
Thank you. Thank you. Excellent.